uh, understanding thyroid associated ophthalmopathy, which is very important.
Can you please put
Dr.
it on?
Apjit Kaur.
So at the outset, I'll say that I chose this topic because very often we miss what is mild thyroid ophthalmopathy. Glaring eyes, retracted lids, this is no rocket science. Everybody can diagnose Graves' ophthalmopathy. The issue arises when we do not see any obvious signs. So that is why I picked up this topic, and because of paucity of time, I'll quickly rush through it. Please move the slide. So we all know that thyroid ophthalmopathy is an autoimmune disease, and it is the anti-thyroid immunoglobulins actually which are the crucial players in this disease. The tissue is, this is not moving. Can you please permit it to move?
Yes,
Yeah.
it's moving.
So it's an intriguing disease because it varies, the whole clinical syndrome varies. You can have euthyroid, hypothyroid, hyperthyroid, all the hormone levels can lead to this. There is no direct correlation between the control of the disease and the control of the thyroid ophthalmopathy. And there is a strong impact on the psyche of the patients. Smoking, we know, is an important risk factor, and the other risk factor is life stress. Life stress, why have I put it in red? Because all the others actually lead to life stress. And this is a little thing which I got up from the book, which just shows that the thyroid stimulating immunoglobulin is the one actually that causes all this trouble of growth of fibroblasts and all. And because it is an autoimmune disease, other autoimmune diseases should be looked for, like myasthenia gravis and Addison syndrome, vitiligo and pernicious anemia. Interestingly, Yersinia enterocolytica infection of the GI tract has also found an association with tau. Clarithrine-mediated signaling pathways, the palmitate pathway and the thyroid 1 surface markers are all there. So the concept of severity and the concept of activity, these are two important concepts. I'm not going into detail. The disease follows the Rundle's curve, which means that there's an active phase and then subsequently it plateaus. So I like to address this disease in 7 commandments. The first is that the lid should be your guide. Age, laterality, site of involvement do not matter. And the surrounding skin shares the burden of the disease, which means that there is upper lid retraction, there is temporal flare, there is lag on down gaze, there is eyelid fullness, there is incomplete or infrequent blinking, and there is resistance to downward pulling of the retracted eyelid. Why is this important? Because when it is happening because of just sympathetic overstimulation, you will be able to pull down the lid. But when it is a fibrotic lid which is retracted, you will not be able to pull it down. There are absent lid creases on the forehead. This is very often missed. And glabular rhytids again. People think that this patient is used to frowning. No. Many times it is associated with an underlying disease. That doesn't mean that everybody who is frowning needs to go and get a T3, T4, TSH done. Look at the whole patient in totality. The second commandment is that the ocular surface partakes in the disease. Do not miss the corkscrew vessels, do not miss the exposure keratopathy, do not miss the chemosis. And the superior limbic keratoconjunctivitis is, incidentally, for everybody's knowledge, it's a prognostic factor now in the management of thyroid ophthalmopathy. We have seen patients who have lost their eye even though there was no exposure keratopathy because of the underlying primary corneal involvement of the disease. The third is that extraocular muscles demand attention, both in action and in visualization. Action, of course, you will get to know clinically, but visualization is important because the patient may be asymptomatic, just a dry eye or just a pain in the orbit, like dull aching pain behind the eye. So currently the absolute diffusion coefficient has become a very sensitive tool in my thyroid eye clinic. Every patient undergoes an MR with a calculation of the ADC values as a baseline. The fourth commandment is that do not underestimate the soft tissues, both in active disease and in healed severe disease, because it is the fat and the facial scaffolds which give rise to most of the presentations. The first wall, the concept of the first wall is that now decompression is done by removal of fat and not by bone. The facial scaffolds, of course, are very important. Fat is seen as enlarged on CT scan, on MR, and the dilated superior ophthalmic vein is very important. Why has it stopped moving? The fifth commandment is that don't neglect the lacrimal gland. Both clinically and radiologically, we know that there is aqueous deficient dry eye in tau. And the lacrimal gland prolapse, of course, can often be thought as a fat pocket on the lid. So look at the scans very carefully. The sixth commandment is that tight space is called compression. The compressive optic neuropathy, of course, is the really danger sign of thyroid-associated ophthalmopathy. But don't forget the secondary glaucoma in cases of healed fibrotic thyroid ophthalmopathy. The disc may be hyperemic, there is visualization which may be difficult because of the corneal involvement that has happened. So have a high index of suspicion if there is diminution of vision along with pupillary involvement. Apical crowding and straightening of the optic nerve are important radiological signs. Compressive optic neuropathy, of course, can be very easily seen on scan. And a rise of 8 millimeter or more on up gaze should raise an alarm. But do not sit back in a patient of tau, because this disease is dynamic. What is simple today may become complex. And based on so many of my research theses, I have sort of summarized that the quality of life improves significantly after treatment at all stages of the disease. It correlates directly with the oxidative stress, and these markers never reach the normal baseline, even if you do not have any evident marker. ADC is altered even when the conventional MRI is normal, and pre-perimetric damage of retinal nerve fibers is detectable on OCT. Avoid getting patients like these who had been visiting the doctors several times but ultimately became blind. Thank you for your kind attention.
Thank you,
Any
ma'am.
questions? I try to stick to my time.
Yes.
Thank you, ma'am. That was a excellent talk. All of us, I'm sure, benefited so much from it. So, any questions?
Ma'am, in how many cases of thyroid ophthalmopathy do the symptoms, all these lid signs and this proptosis, lid retraction, they subside after starting the therapy, after the patients become euthyroid?
If you saw my slide carefully, I had very categorically said that the curve of the thyroid eye disease does not follow the
that
curve
of thyroid disease.
So there is no way of predicting. That is why in my practice, I have now set up, practice means I work at the King George Medical University. I have started a separate thyroid eye clinic once a week, so that patients who, and plus it's a multi-speciality clinic now. So we liaison with the immunologist, we liaison with the endocrinologist and the radiologist to be able to give a patient-centric approach. So there is no way of predicting how the eye is going to behave despite your treatment. Yes, IVMP definitely has a very important role in case there is active increase in proptosis or there is active diminution of vision.
I just wanted to know if you see a case of upper eyelid retraction, it happens to be like within 1 year of the time frame, we call it active
Or
would you like to give some triamcinolone injection around that area?
I have stopped using triamcinolone because I found that this local anti-inflammatory action of triamcinolone doesn't last. The body literally washes it off within 2 months, and after 2 months the patient is back. If I'm sure that this retraction is because of tau, I rather do a mullerectomy once the retraction is stabilized. In the meanwhile, I prefer to do a low dose of Botox
Okay.
to get the lid down.
Thank you.